Welcome. My name is Felicia Morton, and I am the founder and executive director of the CGD Association of America. I am very proud to bring to you today a very special webinar, Advancing Transformative Therapies for CGD. It's part of our Coffee and Clinicians focus, and as many of you know in our community, we look for opportunities to bring the top clinicians who are experts in CGD and, in this case, gene therapy to you to hear the latest in gene therapy and in CGD. And as many of you know, this is such an important topic because this is on the minds of all of us. I can tell you that when I was considering options for my son after he was diagnosed with CGD back in 2012, this was something that everyone was talking about then. But at that point, we didn't have the options that we do now. So this is a wonderful opportunity to learn what those options are from one of the top experts in the field. And we're so grateful to Dr. Donald Kohn for joining us today so that we can have this opportunity to learn from him. We're also very grateful to Prime Medicine for sponsoring this exclusive webinar. Dr. Donald Kohn is a distinguished UCLA Professor of Microbiology, Immunology, and Molecular Genetics. Dr. Kohn is renowned for his expertise in gene therapy as well as CGD, and I've been very honored to know him over the years through my work as a patient advocate group liaison for CGD with the Primary Immune Deficiency Treatment Consortium, where I've been able to hear his presentations over the years regarding the latest in immunology. And it's our great honor at this point to introduce Dr. Donald Kohn.
Well, thank you, Felicia. So I just have to open up with a warning that I'm just getting over a very, very bad case of flu. So hopefully my voice will hold out and I won't lapse to coughing, but starting well at least. So let me open up my slides.
You sound great.
Good. Okay, are you seeing that?
Yes.
Okay, so that's the title. I'm going to talk about gene therapy for CGD, and my intent today is really educational, to sort of cover what is it, what's been done, what's going on now, where is it going in the future. And some of, up until recently, it's mainly been in the academic area. Now there are companies involved, and so I'm trying to prevent really a fair and balanced presentation of the different options and approaches that are out there. And so this is just the my conflict of interest statement, and I have no financial conflict interest in any of this. I am a site investigator for the Prime Medicine study for CGD P47 that I'll talk about. I'm also the chair of the Data Safety Monitoring Board for a trial going on in London at University College London, Great Ormond Street Hospital for a lentiviral vector for P47 CGD, and I've consulted for Insoma for their trial under development for X-CGD. So this is what I will cover during the talk. I'll give a brief introduction to gene therapy for blood diseases. What is it? How do we do it? And then I'll cover a little bit of what happened in the past. And I think the first efforts at gene therapy for CGD were done by Dr. Harry Malik and his colleagues at the NIH in the mid-1990s, late 1990s. And then really moving into the modern era, sort of in 2005 or so, with the current trials and newer ones. And then I'll talk finally about one that's upcoming from, that's a completely different approach. And so first, the introduction to gene therapy for blood diseases. And so my hematology union requires me to show this at all presentations of more than 10 people. And so this is a blood cell tree. And so on your right, as you look at the screen, are the blood cells that we see in circulation, the T cells, B cells, red cells, neutrophils. And all of these are made back in our bone marrow from stem cells. And so we talk about stem cells a lot because they are really remarkable cells. They have the ability for your entire life to self-renew their population and maintain a pool of stem cells, but then some of them go on to commit to either become the different types of blood cells. And so when we talk about a bone marrow transplant, it's really these stem cells that are important. And in fact, now clinically, we usually don't use bone marrow. We more often use mobilized peripheral blood, and I'll talk about that. And so more commonly, we use the term hematopoietic stem cell transplant, but it's really these wonderful cells. And so if you give them from one person to another and they grow in their bone marrow, they can make their blood cells. And so there are many different genetic inherited blood cell diseases that are listed on the right. And so we're going to talk today about CGD, but there's others affecting red blood cells like sickle cell disease, affecting T and B cells like severe combined immune deficiency. And really kind of a one-size-fits-all approach is to give stem cells from a healthy donor, and they will make the needed cell population. And so we're going to focus on CGD, and those are the main white cell there involved is the neutrophil. And so neutrophils start out their life from the stem cells in the bone marrow. They sort of become teenagers, then they go out into the bloodstream and they circulate around. And when they come across signs that there's an infection in a tissue, they stick to the wall of the blood vessels and crawl their way out into the tissue so they can eat up the infectious agent. And then once they've done that, they basically kill the bacteria or fungus by making a superoxide or sort of a bleach for them. And it turns out in a sort of a cousin disease, leukocyte adhesion deficiency, the cells can't do that adhesion step. So even though they can function, they can't get to the scene of the fire. And in CGD, the cells get to the fire, but they can't put it out. And so they just accumulate, and this accumulation of white cells is by pathology terms called a granuloma. So that's where the term granuloma comes from. And so those clusters of white blood cells develop under the skin, in organs, et cetera. But the infections may linger for a long time because they can't really eradicate the organism because they can't make this superoxide burst. So it turns out the way that superoxide bleach is made is there's a group of at least 5 or 6 proteins that work as a complex and generate superoxide, hydrogen peroxide, things like that. And CGD results from if you're missing the gene for any one of these proteins. And so most commonly is this gene called CYBB that encodes a protein called GP91-FOX. And that means a glycoprotein of 91 kilodaltons. And that's on the X chromosome. So that form of CGD almost exclusively involves males. And then the second most common, and these are the two that I'll talk about today, is this other component called P47. And the gene is called NCF1. And if you have mutations in that gene, you can't make a functional complex and you have the same disease. And so there are nuances in the severity with the different proteins, but they're all, I think, relatively similar. And it's the inability to clear infections primarily. Plus, there's sort of a systemic inflammation that we don't fully understand what causes it. But that can lead to colitis and other of the symptoms besides infections. And so we know that we can cure these diseases in a patient by transplanting stem cells from a donor and engrafting them, because then they can make white cells that can work. But transplants from donors have immune risks, and that the patient could reject the cells, because even though they can't kill bacteria, their T cells can still reject cells, or the donor cells can attack the patient. And that's something called graft versus host disease, which is a really significant complication of some transplants that can go on for a long time, where there's ongoing inflammation from the donor's T cells affecting the patient. And these risks increase as the donor is less well matched. So best is if you have a matched brother or sister who matches for all the major tissue types. Next best probably is a matched unrelated donor, like through the registry. And then the sort of the least good match has been using a parent or a sibling that only half matches. Now, there's definite continual progress in doing this. And so the outcomes, even with what was the worst choice, a parent donor, have continuing to improve. And so that's great. And so it's kind of a race for the patient's benefit between transplants from donors versus gene therapy. So gene therapy uses the patient's own stem cells, which are a perfect match, and so the risks of rejection or graft versus host disease are essentially zero. And therefore, we can give a lot less conditioning, which is the chemotherapy we give before the transplant for gene therapy, where we typically give one drug called busulfan, and I'll talk about that. Versus when we transplant from a donor, not only do we give the busulfan to sort of make space for the donor cells to grow, we have to give a lot of immune suppressive drugs to prevent rejection and graft versus host disease. And so that's really one of the potential advantages of gene therapy. It's your own cells, you're not going to get graft versus host disease, and there's less medicines involved in getting the transplant. And so from the engineering standpoint, the technical challenge is we have to get the gene to be normal in the stem cell. Because once you fix the gene in the stem cell, then all the blood cells it makes will inherit that normal gene and function normally. And so if it's a CYBB or an NCF1 gene for CGD, if you get a good copy into the stem cell, it will function in the neutrophils that are made. And there's kind of two main ways to do that. And so for many years, it's been to add a good copy of the gene with a virus. And so we can clone genes into viruses and use that virus to insert the gene into the stem cell. And then more recently, we can actually edit the broken gene right in the stem cell. And then just one other point on this, you'll see the term CD34. That's a protein that's on the surface of the stem cells and the sort of the teenage cells. And so often when we're processing cells from a patient, their bone marrow or their mobilized blood, we isolate the CD34 positive fraction just to enrich our targets, because these 99% other cells, while important, are not necessary for getting the graft. And so this is my cave art cartoon of how it works. We start with the patient, we collect their stem cells, we isolate the stem cells, and then we put them into culture. And then again, in the gene addition approach, we've cloned a copy of the normal gene into a virus, typically a lentiviral vector, that has the properties of it will go into the cell and integrate this DNA into the chromosome DNA of the cell. So once you've put it in the chromosome, it's there forever. And when that stem cell starts dividing and make millions and billions of babies, they'll all inherit that normal gene. Or now we can edit that the gene in the patient's stem cells using things like CRISPR base editing and prime editing, and I'll talk about those in a bit. And then typically while that's going on or after that's done, the patient gets some marrow conditioning, as we refer to it, basically chemotherapy to get rid of the rest of the marrow cells so there's space that when we give the cells back, they can sort of fill up the whole pond themselves. So the cells are just given back. And the transplant's actually the easiest part because it's just an intravenous infusion, like a blood transfusion. It usually happens in the patient's hospital room, not in the operating room or anything. And so this shows the process of collecting peripheral blood stem cells by leukapheresis. So it turns out unexpectedly that if patients get a growth factor, GCSF, which is often sold as Neupogen or a variety of other versions of that, used typically for chemotherapy patients to drive their white count back up after they get chemotherapy. If you get high doses of that for 5 days and then add another medicine, plerixafor, the 5th day, probably 100-fold more stem cells are in the bloodstream than normally. So they leave the bone marrow, they go into the circulation. So to collect the stem cells, the patient doesn't have to have an operation in the OR. You just run an IV line from their vein to a machine that collects some of the blood, and it actually spins a sort of a gradient, sips off the stem cell fraction, and returns everything back to the patient in another IV line. So over the course of about 3 or 4 hours, we can collect their whole blood volume 2 or 3 times and get enough stem cells in 1 or 2 days of doing this to do the whole procedure. So this is what it often looks like, the collected peripheral blood stem cells. And sometimes they're used directly. For our purposes, we're going to CD34 select and gene modify. And so this kind of, again, shows sort of the processing or manufacturing of the drug. So we collect the stem cells, as I talked about, by leukapheresis. They go to a clean room laboratory where everyone's wearing spacesuits and the air is ultra filtered to make sure the cells don't get contaminated. We get rid of the red cells and platelets that might have been collected. We CD34 select our target cells and put them into culture bags and let them grow for a day or two, add the virus. or do the editing thing and then freeze them down, cryopreserve. And then we'll do a whole series of tests on each patient's cell product, and it has to pass 100% of them before it's released. So drug product qualification, are they viable? How many are CD34, vector copy number, et cetera. So we have specific criteria so the patient won't start conditioning or anything until you know you have a good product for them. And then when they do, they will get their chemotherapy conditioning and the cells infused. So this is my sports analogy version of what this conditioning thing is about. So a patient's bone marrow might be full of these USC Trojan footballs. So that's sort of at rest, our marrow is kind of full. And so if we give either no conditioning or fully myeloablative wipeout conditioning in between, the marrow is left looking, looking like this. And so if you give no conditioning, there's very little open space for new cells to grow. Whereas if you really wipe everything out, it's an open niche and cells can engraft. And you can even give sort of an intermediate amount and make some space and get some engraftment. And for SCID, another disease I mentioned, the bubble baby disease, if we just get about 10% donor cells engrafting, that will be enough, or 10% gene-corrected cells engrafting, that will be enough. But for CGD, we really need to get a large number of cells engrafting. And so then we transplant these heroic UCLA Bruin basketball stem cells. And so when we didn't give any conditioning, there's minimal donor chimerism or engraftment. Whereas when we made space, we have now all of our donor cells engrafting, and that's the intermediate case. So that's the idea of why we're giving the chemotherapy, which is really the biggest part of the whole procedure, and we'll talk about it. So the conditioning used prior to infusion of gene-modified stem cells is a chemotherapy drug called busulfan. And busulfan is effective at eliminating the stem cells in the patient bone marrow of making space for the infused stem cells to engraft. But as I said, it has significant side effects. So most patients who get sort of the high dose of busulfan that we use will develop sores in their mouth and their GI tract that can be very painful for a week or two. And often patients need to get narcotics for pain medicine, might need to get intravenous feeding. And so it's miserable. And I've gone through it, not myself, but with multiple patients, and it's tough. And then it gets better once the blood cell counts start growing back. Often there will be partial or complete hair loss. It almost always comes back. We've gotten very good at controlling chemotherapy-related nausea and vomiting. So we have a number of good antiemetic medicines that can really minimize that. There's a rare risk from busulfan of liver injury, usually more commonly in patients that have had leukemia, they had a lot of chemotherapy before their transplant, but rarely that can happen just after one treatment. And then one of the other big issues is infertility. So busulfan, just as it kills the stem cells in the bone marrow, it kills basically the stem cells in the gonads. So the cells, the eggs, or the sperm-forming cells. And so most people who go through the dose of busulfan we give will no longer be able to get pregnant naturally. And so there's a possibility in advance, if you plan to have children later, to freeze eggs or to freeze sperm in advance, and then an in vitro procedure can be done to create a baby later. But that's probably after the mucositis, that's either the number one or number two issue from the chemotherapy. And then there's low risks that the chemotherapy can cause cancer or lung problems, but those are quite rare. And there's a lot of work to develop new methods for conditioning, not using chemotherapy, but antibodies to stem cells to make space in the same way, but not by poisoning the stem cells, but by sort of shooting them with arrows of antibodies. And there's promising work in mice, but bringing those to the clinic as a drug is a slow process. And it's 3 to 5 years away for the last 10 years. And so CGD, the slide says X, but really anyone's, is a good candidate disease for gene therapy. And part of it is we know that women who are carriers of CGD sometimes have not 50-50 of their cells expressing the good gene or the bad gene. And those that have at least 10 or 20% of the good gene on in their cells usually don't have severe infections. So we think if we can get at least 10 to 20% stem cells engrafted with the gene, making 10 to 20% neutrophils with the gene, that should be enough to really get rid of the major infection risk. So that's the threshold that's often looked at. And then for CGD, we know the genes, but there's no selective advantage for the corrected cells. So as I mentioned in SCID, we only need 5 to 10% corrected because the T cells that they make can fill up the empty compartment. So therefore, we need to really give full ablation to achieve engraftment of a high percentage of gene-corrected stem cells. So it's not ideal, but this is the best we've come up with so far. So that's sort of the background. Then I'll tell you briefly about what's gone on in previous trials. So this is kind of a busy slide. It lists on the left multiple centers that did trials, late 90s, early 2000s for CGD. And the important thing is in many of the trials, the stem cells just didn't even engraft. And we're using earlier types of vectors. We're using lower amounts of chemotherapy. There were 2 trials that I'll talk about in more detail where there was engraftment of stem cells making 15 to 20% gene-corrected cells. But in both of those trials, patients developed a severe complication from it, a type of leukemia. And so this is the original report on when it was successful, the correcting CGD by insertional activation. So the report was 2 patients in their mid-20s with X-CGD and chronic infections that weren't responding to medical therapy. And so in this case, it used a retroviral vector, which was the earlier types of viruses we use derived from mice that are very efficient in getting into cells and drive a lot of production of the gene we need. And so they use mobilized stem cells, lowest dose of busulfan. And this is one of the figures from the paper. So across the top is the percent of oxidase positive neutrophils in their blood. And so in this patient for the first year and a half, had about 20% corrected cells. So had reached that threshold. But then over the next year, that number went up much higher. And then in the second paper, patient kind of stayed around 20%. And then there's a test, I don't know if I've showed these before, dihydrorhodamine or DHR. It's a chemical you add to neutrophils, and if they're activated, they will oxidize it like they think it's a bug and fluoresce more. So these are the non-fluorescing cells. Once they're stimulated, you can see that this group of cells are now fluorescing because they got gene corrected. And so this patient had, looked like about half their cells were corrected. And this is an older test, the NBT test, where you add a dye to cells, to neutrophils, and if their oxidase system is working, they'll turn blue. And so you can see the patients both had oxidase positive neutrophils. So this was sort of the first positive result. So in both patients, these resistant pre-existing infections cleared. So it shows the power of this. They both went on to develop leukoproliferation. Time out. Or sort of a pre-leukemia. In fact, one of the patients developed an infection and died. And one was rescued with a bone marrow transplant from a donor. So this study showed this can work. There was a high risk from the type of vector that was being used. This is sort of early 2000s. And so let's move into the modern era. And so the types of viruses that were used in those early trials are kind of cartooned here, where the virus has this element called the long terminal repeat, the LTR, and that drives expression of the gene that we want to make. But they can turn on a gene near the site where it went into the patient's cell's DNA. And that's in fact how they cause leukemia in mice. And so the field went on to make a way of vectors that don't have those enhancers, so they self-inactivate, or SYN vectors, and the gene is run off an internal promoter that can be safer. And so this vector was made by a group of investigators, Adrian Thrasher, Juan Braran, and Manuel Grez in Europe, where they drove the normal CYBB gene for XCGD off a cellular promoter from two genes expressed in neutrophils, cathepsin G and C-Fes. And their thought was that it would express the gene in the right cells, but not in the stem cells that could get turned on and grow out. And in their preclinical studies, they showed that in mice, it expressed nicely in neutrophils. Now, this is cells from a patient. Again, this is that DHR test showing expression. So in the healthy donor, this is the group of neutrophils that are positive. From a CGD patient, untreated, they were all not reactive. And then once they put that vector into them, they now had cells that responded and made the oxidase. And so that went on to be used in several clinical trials. And actually, I don't have one listed here that I'll mention in a bit that was done also in France. So in the UK, they treated several patients at Great Ormond Street Hospital, UCL. In the US, I was the sponsor for a trial that was done at Mattel Children's in UCLA, Boston Children's, and NIAID. And this all grew out of a European consortium. And so Genathon and Ypacasi in France made the actual clinical batches of vector. And Rick Bushman analyzed the samples for a vector site. And so the criteria for the trial it was for males with CGD above basically 2 years of age and above. They need to have a molecular diagnosis confirmed by DNA sequencing with laboratory evidence of reduced activity of the oxidase system. And we wanted patients who had previously shown that they're susceptible to infection. So you need to have one prior ongoing refractory infection, inflammatory complication. And since a transplant from a brother or sister was still the gold standard, if they had a matched sibling donor, they were not eligible. And then we wanted to make sure they didn't have any ongoing viral infections listed there, and they needed to give consent. And so this is the sort of the schema for the patient as we kind of talked about. So if a patient was interested, they would undergo the informed consent process. They have screening tests to make sure they were eligible for the study in terms of the disease criteria I mentioned, and also adequate function of liver, kidney, heart, et cetera. And then they were enrolled. And so then they would get their stem cells mobilized, as we talked about, leukapheresed. They'd go to the GMP laboratory that would isolate the cells, transduce them with the vector to put the gene in, and freeze them away. Plus, some cells were frozen away untreated as a backup in case the frozen cells didn't work. And it typically takes 4 to 6, 8 weeks or so to do all those testing to make sure the cells are perfect. And when they are, then the patient would come in and get busulfan in this trial over 3 days, and then the cells were infused a day later. And so this was the first patient who was treated. So at Boston Children's, patient 101. And he'd actually been seen at the NIH 10 years earlier when they had done an NBT test, and he didn't make any blue cells. So he had, as part of his CG diagnosis, and now he is. So it showed that, we've restored that aspect. And then by the more modern test of DHR, you can see at 1 month, 1 year, and even 2 years, he has this nice population of neutrophils that can make oxidase activity. And so in this trial, the first 5 adults that were treated did quite well. And so you can see this is the level of DHR positive. So they've all stayed above that 20% threshold and really done quite well. And they're probably now out 8 to 9 years for the longest one. However, we then treated 4 pediatric patients between about 2.5 and 10 years of age. And they all had initial engraftment and then slowly lost most, but not all, of their gene marking. And we didn't know exactly what that meant. But in fact, I mentioned a trial in Paris was being done. They saw a similar thing. So they treated 4 patients, and 2 of them had nice stable persistence of gene-containing cells and DHR, but 2 of the patients lost almost all their gene marking. And so while there was stable persistence in oxidase in the 5 adult patients, they remained in good health. 4 pediatric patients lost almost all, but not all, of their markings. They have about 1% DHR positive neutrophils, and 3 of them have been well since treatment 5-6 years ago, continuing on prophylactic antibiotics. One of the patients, despite prophylactic antibiotics, developed an unresponsive Aspergillus infection and underwent a haploidentical transplant, but unfortunately died after the transplant from complications. So my colleague here at UCLA, Caroline Kuo, who's a pediatric immunology allergist, has been looking at the samples of the cells that we gave to the patients. When we freeze the cells, we save extra samples to test later. And she can see an inflammatory evidence for high levels of gamma interferon in their stem cells. So all the CGD patients have more gamma interferon than the non-CGD patients. And those 4 that lost most of their marking had higher levels. So this is related to inflammation. So just like the inflammation, again, in colitis, there's inflammation in the bone marrow that seems to be higher in the children. So that kind of completed the study we proposed to do under the grant we had from the California Stem Cell Institute. And so just in this last week, we've transferred the IND to do more trials to the NIH, to Dr. Elizabeth Kang and Harry Malak, who will plan to administer interferon blocking agents before the stem cell collection and or the transplant, as they've actually been doing with transplants from donors. And so it wasn't perfect. Some adults got a great result from it, and we learned about a potential problem from some of them that hopefully this new approach will resolve. So then lentiviral vector trials for P47 autosomal recessive CGD. So the same investigators in London that made the vector for XCGD basically swapped the gene and put an NCF1 for P47 CGD with the same promoter. And they did all the preclinical work to show the EMA in Europe, the FDA in the US, that it looks effective. And so they are now open for trials. And these are the clinicaltrials.gov numbers for the trial in London and in NIH Bethesda for patients with P47 CGD. And I mentioned in my disclosure that I'm on the Data Safety Monitoring Board for the London trial. And I can tell you they've treated the first patient safely, and at least early on looks like it worked nicely. And so these are just issues about the trial design. Over 6 months of age, molecularly diagnosed, severe infections, no 10 of 10 related donor, and they make the drug product successfully. They'll look for engraftment and then safety and other issues. So those trials are just getting off the ground now, as is this next one, which is the prime editing trial for P47. So this one is not using a lentiviral vector or a retroviral vector. This is a very new, very, I think, exciting and complicated, as you'll see when I explain it, method to precisely edit the human genome to insert just one or a few bases to correct small deletions. And so it's like, you know, in a word processor going in and, you know, as I do all the time with all my typos, going in and pasting in the 2 letters that are missing. And it turns out that 90% of the people with P47 CGD have, the mutation they have is a 2 base pair deletion in NCF1 that causes their CGD. And it's likely a copy error from flanking pseudogenes. So pseudogenes are sort of, you know, the Michael Keaton movie, the copy of the copy of the copy. So we have some genes that actually duplicate in our genome over evolution and then sort of become inactive. And it turns out that the gene involved in P47 CGD, the NCF1 gene, that's shown in white here, the normal gene, it's flanked on both sides by a pseudogene copy that have a 2 nucleotide deletion. So it's missing the letters GT in the gene, making it inactive. And in 90% of patients with CGD, that mistake has appeared in what should be their good gene. So they have no good gene to make that protein component to the oxidase system, and they have CGD. So the method of prime editing is just perfect for replacing those 2 nucleotides. So I'm going to try and explain this to you. This is kind of takes a, if not a PhD in biochemistry, a good high school biology in the last decade. But so the technology of prime editing is based on something that's called CRISPR. So about 12 years ago, Jennifer Doudna at Berkeley and Emmanuel Charpentier in Paris found in bacteria they had a system for attacking the DNA of viruses attacking the bacteria. So just like we get viruses infecting us, as I can tell you, bacteria also get infected by viruses. So they developed a system to take some of the DNA from the virus the first time it infects it, copy that into RNA, and the next time that virus sticks its DNA into the cell, it binds this protein to it by matching the RNA it makes to the virus DNA and chopping it. And so it's basically a very effective defense system once the bacteria has seen a virus. And so they realized that this could be turned into a human gene editing tool. And so what the two parts, so it's this protein that has the ability to cut the DNA, and then it binds an RNA. Part of the RNA, this upper loop here, brings in the protein, and this part here matches the DNA, AT-GC base pairs. So you can design this little part to match any target you want in the human genome, like against the NCF1 site, or we're working for sickle cell disease to have it bind against the hemoglobin gene. And that cuts it and inactivates it. But prime is an order of magnitude more elaborate. So it uses that basic Cas9 protein with the RNA that brings it in, and the RNA that will bind to a DNA, but it's fused to another enzyme called reverse transcriptase. So reverse transcriptase is an enzyme from retroviruses, so we kind of reuse parts, that can copy RNA into DNA. And so the RNA that's made, the PEG RNA, besides having the part that recognizes the target DNA, the part that brings in the Cas9 protein, has this part that has the sequence you want to paste into your target site. So you add this to the patient's cells, gets into the DNA, it binds near the target site like NCF1, it makes a cut just on one side, that long piece of RNA binds, and then the reverse transcriptase copies that piece into DNA, and it winds up pasting that new sequence into the DNA. And so for P47, it replaces those two missing nucleotides. It took me months to wrap my head around how this works. But that's the basic technique. It's a very precise editing tool. And so they have very nice preclinical data showing how this works. And so here they're treating patient cells with, or cells made from a healthy donor with the editor, and then putting them into immune deficient mice to see how they grow. And those that were prime edited grew exactly the same in the marrow as those that were not treated. So the cells are not harmed by it. And they corrected 90% of the mutations in the cells. So very highly efficient. Remember, our threshold is 20%. And then they measured that 80% of the neutrophils made from these cells had oxidase activity. So at least in this, in the laboratory study, it looks highly efficient and safe. And so this is sort of their outline of their trial. And I thank you, Prime Medicine, for sharing these slides. So it's the same kind of procedure we talked about: enroll, mobilize, manufacture, condition, give the cells, follow the patient. The manufacturing, though, instead of being a lentiviral vector, will be the prime editing. And they plan to treat patients in 3 successive cohorts of younger patients. So starting with adults over 18 first, which the FDA almost always insists upon. And then if they get safety and meet certain parameters and reviews, then they will start enrolling teenagers. If they, again, meet safety parameters and reviews, they will then treat younger children. And the criteria that you have to have that specific mutation in the NCF1 gene to be eligible. And their IND cleared and the trial is open now and they're enrolling. And then, so the last area I'll talk about is sort of ghosts of future near Christmas. And it's a completely different approach. This is from Ensoma. And what they're using is a virus to actually deliver the gene into the cells in the body. So they're not going to do a stem cell collection, treat the cells in the laboratory and reinfuse them. They're going to give a virus into the bloodstream to deliver the normal CYBB gene to the patient's stem cells. So they mobilize the stem cells, they're out in the circulation, and they give a virus that carries the CYBB gene, and then also a chemotherapy resistance gene. And then another vector is given at the same time that makes this integrate into the DNA of the target cell. And so the journey is the patient gets mobilized, but not collected. It's just while the cells are in circulation. Then this virus is given along with immune prophylaxis to try and prevent an immune response to the virus particles. And then ideally the virus gets into some stem cells that go back to the bone marrow. And then afterwards, they give some chemotherapy, much, much less than high dose busulfan, typically in 3 cycles, which will select for the cells that took up the gene. And so here's a piece of their data in mice showing these are mice treated, and then 3 cycles of selection, and they went up to 35% cells with CYBB, again, above the 20% threshold. So I don't know exactly how far away this is from the clinic. I think it's within a year or so. And so it delivers the normal CYBB gene into the bloodstream, targeting mobilized stem cells. It avoids the need for stem cell collection. It avoids the need for conditioning. So that would be huge if this is effective, and cell infusion. However, it's a relatively low efficiency getting the gene into the stem cells in that first pass. So it requires post-treatment selection for the gene-corrected cells with a chemotherapy agent called temozolomide. And it remains to be seen what final level of corrected cells will be achieved in the patient. So it's a new approach, so we don't know. And there is the potential for immune response to the virus given IV to carry the gene. Again, they're going to try and prevent that with some immune suppressive drugs at the time. So in summary, patients have benefited from gene therapy for XCGD, further learning from treated patients to guide future trials, as what we saw with the patients who lost their marking, increased understanding of the role of inflammation in stem cells in the bone marrow niche. Gene therapy, when available, and that's another point, is that there's very limited trials, and so it's not widely available, unfortunately. And to make any of these widely available, in the U.S., they need FDA approval. It offers an alternative treatment for patients that are transplanted from a donor, the improved lentiviral vector protocols, many new gene editing approaches being developed. In vivo gene therapy has significant potential advantages, and P47 CGD trials are now open, and more is coming. And I just want to acknowledge some of the slides were given to me by Claire Booth at UCL, Mohammed Asmal at Prime Medicine, and Drew Dietz at Insoma. And I just have to mention my sponsor for the US CGD trial, the California Institute for Regenerative Medicine, the Stem Cell Institute, funded the trial at the 3 sites. And thanks for Felicia Morton for inviting me to speak.
Thank you so much, Dr. Kohn. That was such an enlightening and informative look at what is happening right now in gene therapy for CGD, in addition to a good backgrounder on what CGD is and how it affects patients, so that we can truly understand how gene therapy can correct CGD. And I wanted to turn it over now. We do have some questions from the audience, and I wanted to thank everyone who has participated and who has joined us today in this webinar. And some of the questions that we received are regarding whether or not a patient should wait. We saw that the P47 clinical trial is now open, and that's also considered autosomal recessive, right? That's that's also another term for this type of CGD. So for these patients who have P47 CGD, they're wondering if they should wait a few more years or if they should join now, because if they wait a few more years, then they might be able to see the results of some of the early clinical trial studies. What are your thoughts on that?
I mean, I think that's the dilemma that every patient faces. We know that with CGD, progressively, patients will have infections and problems. Will it be next year, 5 years, 10 years, and where will the technology be then? So it's a real hard decision to make. We think we're getting better, but then also some gene therapies have been available in trials. Trials were completed, they didn't get picked up by companies, and they're not available anymore. So there's some, if it's available, maybe it's something to consider. I think most CGD physicians would recommend that if people with CGD have a donor, they should have a transplant. I think, having the gene therapy option would be similar. So it's an individual decision. Um, um, when it's available, taking the opportunity when it's available, or waiting till there's evidence and not being the first one.
Okay, thank you for that answer. We also got a more specific question from one of our patients asking that they have heard from their doctors that they should consider curative transplant soon because they've been having a lot of severe symptoms, and their doctors have advised that they should really look into a curative option as soon as possible. In this case, they're wondering if they should go ahead with more of a traditional bone marrow transplant.
I mean, I think those are two different issues in there. One is, should I do a transplant? And the other is, which should I do? I think there's enough track record to know that the gene therapy approaches are effective, probably safer than a transplant from a donor overall. And so I think, if you make the decision that you want a curative therapy or a definitive therapy, then, if there's a gene therapy available for it, I would think that that's what I would recommend, to take that opportunity. But again, it's sort of an individual decision. It depends on the availability of a donor.
Right. Thank you for that. And as you had mentioned in your presentation, in earlier clinical trials for gene therapy, it was seen that pediatric patients did not do as well as adult patients. And so we did get a question regarding a parent wondering about gene therapy options for their children. What are your thoughts on that? And what are the ages, do you think, when we talk about children, what is really considered a child versus a teen versus young adult?
Yeah. So in the U.S. trial, as I said, the 4 pediatric patients between about 3 and 10 years of age. But it turned out in the Paris patients, 1 or 2 of the patients that lost their marking were adults. And so it's not strictly a pediatric problem. And so again, the work that Dr. Malik group is going to do now, giving more anti-interferon blockage before the procedure, that may solve that problem and make it more available. So it's not clear where that cutoff line is between pediatrics. In the small number of patients we had, I believe our oldest one was 10.
Thank you. And in terms of the side effects, you had touched upon that. What are some of the other side effects that we're not sure about but could possibly happen in both of these types of gene therapy? Certainly there's a clinical trial, and the gene therapy that is expected in a year's time to become available. That's for CYBB X-Linked CGD patients.
I'm sorry, I didn't get the question.
Oh, you had mentioned some of the side effects that are potential or that had happened in previous gene therapy clinical trials. You had mentioned that gene therapy reduces the side effects that we know of, the ones that we're all very afraid of, such as graft versus host, and some of the other issues that are very concerning for us, that prevents many patients from considering, or patient families from considering, traditional bone marrow transplant. What are some of the side effects that the gene therapy options that you mentioned today? What could you talk a little bit about what could be possible?
Yeah, I mean, in general, the experience with gene therapy is it has very little side effects. Again, for our ADA SCID patients with a low dose chemotherapy, they leave the hospital a month and they're never back in the hospital again, and they're fine. And I think once they get over the chemotherapy, it's very unlikely to have side effects. The main concern in gene therapy is that you're manipulating the genes. And so whether you're adding a virus throughout the genome or you're doing an editing, could that somehow affect a gene involved in cell growth and trigger like a leukemia growth? And that's what happened, as I said, in those early trials with the mouse viruses. Hasn't happened with the lentiviral vectors now in the last couple of decades. And I don't think the editing approaches are likely to cause that either.
Okay, great. Thank you for actually explaining that. And there are some questions also in the chat that I wanted to get to as well. And there are currently 10 questions in the chat that we want to make sure that we are able to answer. And in the Q&A box. So I am going to, let's see.
Should we take it from the top?
Take it from the top. Okay.
Okay, so I see, the first question I see is says,
Yes.
mouse lentivirus, does it come from a mouse, and what is the meaning of the name? So I clearly wasn't clear. I was actually talking about either mouse-derived viruses or lentiviruses. And so the vectors that were used to carry genes in the first decade sort of gene therapy were mouse viruses. And then what we've moved to since then is lentivirus. So lenti means slow. Like there's lenti insulin, means slow acting. And so there's a family of viruses that infect all the different mammals and typically cause a slow disease course. And one of those that affects humans is HIV. And so the lentivirus is HIV vector, where all the HIV genes are removed, and just like the CYBB gene is carried by it. So that's what it means. And despite sounding scarier because it's from HIV, they've actually had a much safer track record.
Great. Thank you for that. That's really helpful. And I do see the next question there from our patient audience.
Yeah, so if the issue in CGD is white blood cells that do not create superoxides that leads to granulomas, can you explain how in a successful graft, the healthy cells outcompete with the uncorrected CGD cells? Well, I think neutrophils don't last forever. They last weeks or so at most. And so over time, the ones even in the granulomas will go away, and the healthy ones made from the new bone marrow won't do that. And so it kind of takes care of itself.
Oh, great. And here's a good one too, Dr. Kohn. Do you feel that a patient has to be healthy, quote unquote, in order to get gene therapy? For example, if they're struggling with a bad infection, could they get gene therapy, or would they need to get over that infection first?
Yeah, I mean, in general, some trials only allow patients in who don't have an active infection. And sometimes easier to do, not in the US, but like for in the UK, they can kind of treat patients as doctors make decisions and think, okay, it's a high risk for this patient because they have an infection, but this is the only thing that will work for them. And so ideally, infections are under control before you get the chemotherapy that's going to drop your blood cell counts for a while.
That is really important to know. We have a lot of patients out there who are concerned right now. And you had talked about infertility in very young children. So yes, we know that it's possible to preserve, but if a child is under a certain age, what are the possibilities in that case?
So this comes up a lot with children, young infants with leukemia. And what they can do is surgically take, men don't cringe, a little wedge biopsy of a testicle, or from women, a little wedge biopsy of an ovary, and freeze those. And those will be viable for conception later. And so there are ways to even do fertility preservation in prepubescent patients.
That's right. And so that's something that parents can look into as well prior to thinking about their options. But with gene therapy, it's not as much of a concern, correct?
Well, it's still a concern because of the chemotherapy.
Okay. And so the other question is, this is kind of interesting and timely. Do you use some AI or machine learning for faster research and predictions?
I think I'm of a generation that's not going to be using AI or machine learning, but certainly it's a great set of tools that will be improving research.
Yes, that's definitely something on everyone's minds as well, considering the current news. Are there any therapies that are an option for a female X-linked carrier that's symptomatic? Is there any research and/or other therapies being trialed for female
Yeah.
carriers that are symptomatic? And we know that from our research that we've done at the CGD Association of America that patients who have under 20% working neutrophil are symptomatic, and over 20% they are largely not getting the more challenging infections. So this question would really be for CGD carriers that have under 20% working neutrophil. So what are your thoughts on that? Is gene therapy an option for them, or are there other curative or treatments that are efficacious for this population?
I mean, the only thing we would have to offer are the same options of a transplant from a donor or a gene therapy procedure. I think the current trials tend to try and have a very homogeneous population so they can get a good data set for the FDA. And I think they wouldn't want to bring in the additional complications of carriers. But when these methods work, it certainly could be beneficial.
Yes, we're always thinking about the women in our community. So thank you for answering that.
That was a great study that you did, by the way.
Thank you so much. We really care about our women, and I'm not just biased in saying that. So also, this message is from a patient, family, and a mom. Gene editing, like CRISPR, you mentioned, is a powerful tool that can change specific genes in our cells. However, sometimes it doesn't always target the right place. This means it could accidentally change other parts of the DNA, causing problems like disrupting important genes or even leading to diseases such as cancer. Is that true? You touched upon this in the past, and leukemia being a risk in gene therapy trials quite some time ago. How do you answer this question today?
Yeah, so each CRISPR that you make for a different target has a potential for going other places in the genome. And so the FDA is unbelievably strict about having a large data set showing that you've done research and you've treated cells from multiple people and shown that you don't edit anywhere near any cancer-related genes. And so while it's still theoretically possible, I think with the right work in advance to make sure that you have a safe target, I think it's quite a low risk.
Thank you for that. And we have time for a couple more questions. Is gene therapy effective to help remove the risk of CGD patients who've been cured using BMT from being able to pass it on to future children?
Well, so whether it's a transplant from a donor or an auto gene therapy, it neither changes the sperm or egg and the ability to pass it on and so have an affected child. And so the infertility of the chemo might reduce the risk. That's not the goal. But the gene therapy only changes the blood cells, and it doesn't change the germ cells, the eggs, or the sperm. So a parent could still pass it on.
Okay, and let's see. I think we have time for one more question from one of our patients. Is there anything coming up for us with P67, or are we too few?
Yeah, that's a really good question. It's important, just to mount one of these trials is a lot of work. It's hard to get the funding to do the trial. But it's, if it works, it should be pretty cookie cutter. If it works for CYBB and P47, it should work for P67. And so hopefully, the NIH is really in the US, the bastion of CGD research. And hopefully they will have a successful P47 trial and they'll follow it very quickly with a P67 trial.
Okay, now I'm going to ask our production team, how are we doing on time so that we can be very clear that we can end on the right time? I think that we have about 1 minute left. So it's time to wrap up. Yes, I just got my message here. So I wanted to say thank you to everyone for joining us today from the CGD community. Uh, we are providing more information. If you have any other questions or would like to request more information, please contact us. That information is in the chat. We are so grateful to Dr. Donald Kohn, who has joined us today for this highly informative and educational talk about gene therapy, advancing the therapies for gene therapy, and advancing transformative therapies for CGD, to get the correct term, from our Coffee and Clinician series. And we're so thankful to Prime Medicine for sponsoring this exclusive webinar. Thank you very much, everyone. And we look forward to seeing you at our future Coffee and Clinicians and Zoom calls and on our website. And please follow us on Instagram, LinkedIn, and Facebook. Everyone, really grateful to you all. Thank you and good night.